But why is medication adherence important? Well, the literature tells us that there's about 125,000 preventable deaths every year, so adherence would help those people stay alive. 10% of all hospitalizations are from medication non-adherence, and then it kind of leads to 3 extra medical visits a year, which of course increases our healthcare costs. And then the 2 pieces that are kind of difficult to quantify is patients really do have a decreased quality of life, although they don't see it that way, when they are non-adherent and they get days lost from work. And then there's also, our clinical trials, obviously those patients are adherent. So if we think there's going to be a great benefit from a drug, there is a great benefit, but only if you take it. So let's talk about, there's kind of 3 phases of like full adherence. And the first one is initiation. And maybe this audience knows, but about 25% of patients never fill that prescription that we give them. And then some fill it, but then they don't ever take it because they take it home from the pharmacy and they read the stuff that's in the bag and then they get scared. So initiation is a problem, but let's say they initiate the drug. Implementation is actually taking it as prescribed. Well, we have a lot of patients who will miss doses from time to time. 62% of patients who are studied who have hypertension, type 2 diabetes, or dyslipidemia admitted to forgetting to take their medicines, and 37% of them said that's because they ran out early. 50% of patients who are on a dialysis modality have reported being non-adherent to their medications. And then, so implementation is an issue, right? That's kind of taking it every day, getting your refills from the pharmacy, taking it the correct way, like carvedilol twice a day means morning and night, not 2 pills in the morning. And then we have continuation. And this is where patients, they may take it for a while and then they just decide to stop. So I'm going to pass it on to Ms. Jane.
Thank you very much for inviting us. This is one of our favorite topics because it is a constant source of frustration for me and for Rebecca and for all of us as nurses. I do want to say thank you to ANNA for inviting us, and also this is my favorite time of year because it is Halloween, my favorite holiday, and I get to break out my Halloween socks, for which I might add that when I was working in the hospital, I got several write-ups. But I'm not in the hospital anymore, and nobody tells me what to do. We want to hear your questions, we want to hear your comments, but we have to make a fast getaway, not that we've stolen anything or broken any laws, but we've got to catch a plane, so we're going to be zipping out. But if you have any comments later, you can put them in the chat, or you can put them on the ANNA access board. So why are people non-adherent? Well, probably for every reason that you can think of. One is that most of our patients take a lot of medications. Our dialysis patients are often asked to take 4 medications with every meal. That's in addition to their vitamin. Maybe they're still on a statin, and keeping patients on a statin post-dialysis is an individual decision, but many of them are on up to 10 medications a day or more. And the frequencies, once a day, twice a day, 3 times a day, bedtime, it's very confusing. The regimen frequently changes. And then the patients are concerned about the way the medication makes them feel. And Rebecca mentioned this with the handouts. I've had patients who've handed me their pharmacy handout that has all of the complications that are possible. Now, if someone found that they blinked twice after they took a medication and they report it, it becomes an adverse reaction. So I remember very well one patient handed me the list and everything was checked on it. I think it delayed her fertility. She was like 60-something. I don't know why she was worried, but it did cause constipation and diarrhea. So I mentioned to her that I didn't do the best in nursing school, but as I recall, diarrhea and constipation were very different. But she said she had both of them at the same time. Whatever, okay. There was a German study that found polypharmacy ranged from 62 to 86% for patients in stages G1 to 3B. And the multiple comorbidities of our patients make it even more complicated. And multiple comorbidities mean multiple providers. So I recently had a patient who went to her primary, and the primaries, whoever saw her, sent a note back to the dialysis unit that we needed to look at her anemia. Well, her hemoglobin was like in the 10 range, and her iron was fine, which according to regular labs, she was anemic. But we thought she was doing just fine. What I ended up doing was contacting the practitioner who saw her, because in nursing school, in graduate school, the kidneys make urine, move on, and that's all anybody ever knows about it. And I invited the practitioners to come around in the dialysis unit with me, and it was an eye-opener. So what are some of the other reasons? The lack of symptoms. If you had a condition that you couldn't hear, see, smell, feel, or taste, would you believe that you had it? Many of the patients, particularly as they approach end stage, will say, "What do you mean my kidneys aren't doing well? I pee all the time." Has anyone had that experience? Come on, I know you have. Okay, or I'm on dialysis, but I make urine. I don't think I really need it. The lab must have messed up. Anybody hear that? Okay, so they don't understand that, yeah, the kidneys are making water, but that's all they're doing is making water. The severity of the disease. When you don't feel good, are you going to feel like swallowing 7 tablets? No, you really aren't. You're not going to feel like doing much of anything. And depression. Depression is very often overlooked in our population. We should and could, but don't screen for depression as often as we should. Now, I know a lot of clinics, mine included, give a depression survey, and that ends up too often being a checklist. When you say to a patient, "Are you depressed?" or you say to a patient, "I think you may be depressed," it is not a happy thing to say. Because for many of the patients, saying that you're depressed or getting a diagnosis of depression is very negative. It means you think they are weak, that they lack faith, and many other things. But if I were told that I had a major organ that was failing, I think I would be very depressed. And if I were told that I had all of these medications that I had to take and all this stuff that I had to do, and I could no longer, if I were told that I couldn't drink coffee or eat dark chocolate, there wouldn't be enough Prozac in the world to get me over that.